Good afternoon. Today we're going to discuss analgesic drugs. We want to start with referring to some terms that we need to talk about. So we're going to start with pain tolerance. Pain tolerance is the amount of pain a patient can endure without it interfering with normal function. Acute pain is sudden and usually subsides with treatment. Chronic pain is that pain that is persistent or reoccurring. It lasts 3 to 6 months or more. Tolerance or physical dependence. These are changes that occur in the nervous system that often require increasing drug dosages. With tolerance, you also have opioid tolerance, which isn't on here, but it goes with tolerance. And that is the exposure to the drug causes changes in the drug receptors, resulting in a reduced effect over time. So this phenomena really does affect how we manage opioid use, and effective management is really going to be an issue. So sometimes what we end up having to do is you have an additional 20 to 40% more opioids are used to treat acute pain. You want to use longer acting opioids because short acting drugs are more likely to produce a high, which only interferes or reinforces the addictive tendencies. You do also have a genetic differences in the cytochrome P450, which can cause different responses to the drug. So control of a patient's pain takes ethical and clinical priority over the concerns regarding drug addiction. So basically, as nurses, we want to be able to treat the patient's pain. Pain is the fifth vital sign. It is subjective, yes, but we do have objective things that we can see if the patient is in pain, but you are going to medicate your patients for pain besides your ethical or your opinion of whether the patient is just seeking drug or drug seeking or has a addiction problem. So getting back to our terms, breakthrough pain is pain that occurs between dosages of pain meds. You may give a dose of an immediate release form of an pain medication between your doses of scheduled extended release drugs. So one thing to always remember is that you never want to crush or chew an extended release drug. It defeats the purpose. It breaks the enterocoating. Another term is your synergistic effect. And again, these are adjuvants that are used to augment individual drug effects. So meds that we will give that help to accentuate the activity of another med that they're already taking. Analgesic ceiling effect is when the drug reaches a maximum analgesic effect, and giving more medication does not improve the effect of that medication. An agonist will bind to an opioid pain receptor in the brain. A partial agonist usually binds to a pain receptor, but it causes a weaker neuroresponse. So one stimulates one but prevents another. And then you have a physical antagonist, which binds to a pain receptor but exerts no response. So it is opposes, it actively interferes or inhibits the medication or an opioid. Physical dependence, again, is a physiologic adaptation of the body to the presence of an opioid. Okay, so now we're going to start with opioid analgesics. These are meds that are used to treat moderate to severe pain. Their mechanism of action, usually they attach to a receptor in the central nervous system. They alter the perception and the response to pain. You have two types of receptors that opioids react on. And you have your mu receptors, which are analgesia. They cause respiratory depression, euphoria, sedation. The involvement of the mu receptor is linked to the physical dependence. So these are the ones that these are the specific brain receptors in our brain that when they are bounded, decrease the activation or the stimulation of that receptor. And that's important to know because the meds are going to affect either one of these two types of receptors. And then your other receptor is your kappa, which again, those are analgesia, sedation, decreased GI motility. Opioid classifications that you will need to know are your agonist antagonist, and your antagonist. Your agonists are those that attaches to the receptor and produces a response. So you have your meds that are going to cause you to have your agonist. They will cause a response. So if you're giving them morphine, you're going to see the response of morphine. Agonist antagonists are meds that bind to one receptor, causing the response, but they bind to another receptor, preventing a response. So these opioids will bind, let's say, to the kappa receptors, but will to produce the response, but they will bind to the mu receptors to prevent a response. And then your antagonists are opioids that attach to a receptor and prevent a response. The purpose of giving opioids is, again, to reduce pain and to increase activity. So we want the patients to be mobile. We usually will treat them with pain prior to us having them do any type of physical activity, if we want them to get out of bed after surgery, or we need them to be mobile and they have a wound or post-op incision or things like that. This is why we would, the purpose of us giving them an opioid analgesic. Opioids are Schedule II drugs, so they're high potential for abuse. Opioids do have an opioid inhibit neurotransmitter release. So the opioid agonist, again, which binds and stimulates the inhibition of the specific neurotransmitter release. And these opioid inhibit neurotransmitter release is just basically another way of knowing how the opioids work in the brain and how they affect the neurotransmitters, which release the effect of those receptors, which cause respiratory depression, euphoria, sedation, analgesia. So basically, the mechanism of action that all of these meds give us is your altered perception and response to pain. Okay, so now we get to common opioid agonists that are important for you to know. Common names of these agonists are going to be morphine, also known as MS-Contin, or morphine sulfate. Does have a continuous release. Fentanyl is a very potent opioid agonist, and it's so potent that 0.1 milligram of fentanyl will equal the effects of 10 milligrams of morphine. So it is almost 100 times more potent than morphine is. Meperidine, which is Demerol, methadone, codeine. Codeine does have that sealing effect that we discussed in the previous slide. Oxycodone or Oxycontin. The cotton ending does again have your continuous release. It's a family of the morphine sulfate. So they, again, these are meds that you do not crush or chew. When you combine the oxycodone and the acetaminophen, it makes the brand of Percocet, or the that's the brand name, but the generic name would be just the oxycodone plus acetaminophen. And then your oxycodone and aspirin will produce Percodan. Hydrocodone. Hydrocodone is another opioid agonist. And when you combine hydrocodone with acetaminophen, you get Vicodin or Norcor. Vicodin has a higher dose of the acetaminophen, and the Norcor has a smaller dose of the acetaminophen, which is only 325 milligrams of the acetaminophen. So that's the difference, is the amount of acetaminophen that that each of them have, which makes them different from each other. And then you have your hydromorphone, which is known as Dilaudid. And this again is potent as well. 1 milligram of hydromorphone is equal to 7 milligrams of morphine. So yes, not as quite as potent as your fentanyl, but still more potent than your normal morphine sulfate medication. All right, so now that we've discussed the common names of these opioid agonists, we're going to discuss their mechanism of actions, their purpose, and adverse effects. So these are the same opioid agonists that we discussed in the previous slide. So we're going to be talking about your morphine, your fentanyl, your meperidine, methadone, codeine, oxycodone, and hydromorphone. All opioid agonists. They all have the same mechanism of actions, purpose, and adverse effects. So their mechanism of action, again, is attaches and activates the mu receptors and the kappa receptors. The purpose of these meds is to be able to treat moderate or severe pain, pain from post-op, cancer, childbirth, or an MI are going to be your examples to moderate to severe pain. They do have a sedation effect. They will also reduce the bowel motility. So sometimes if we want to sedate the patient, we might give them an opioid. If we want to reduce their bowel motility for bowel surgery or prior to bowel surgery or because of some type of bowel surgery that they had, this is useful for that as well. And again, to suppress cough or cough suppressions, medications like codeine are what we would give for that. Adverse effects of these opioid agonists are going to be your respiratory depression. Respiratory depression is one of the big ones. So again, you want to check your vital signs. You want to stop the medication if the respiratory rate is less than 12 breaths per minute. You want to be able to notify the prescriber, have naloxone and resuscitation equipment available and nearby the patient, because we need to be able to reverse the effects, and that's what the naloxone will do. It will reverse the effects of the opioid, so you want to be able to have that available if the respiratory depression becomes too severe. Constipation is probably one of the big ones because, again, it does have one of their purposes, or because the kappa receptors deal with GI motility, they will have constipating effects. So you want to be able to educate your patients to know that this will be a normal effect or normal adverse effect of the medication. You want to help them increase their fiber and fluid intake, have them continue physical activity, administer a laxative as preventative to make sure that they're not getting constipated. Making sure they're drinking plenty of water is going to be very important. Also, giving these patients the methyl-naltrexone. Methyl-naltrexone is specifically for opioid-induced constipation, and in patients taking opioids daily, it does have a more beneficial effect. These patients are going to be patients that are suffering from cancer and getting cancer treatments or pain from cancer, and patients who are suffering from AIDS. Orthostatic hypotension is another adverse effect. Again, you want to avoid sudden changes in position. You want to help assist these patients with ambulation if possible. Urinary retention. Again, you want to have the patient void every 4 hours. Monitor their eyes and nose. Assess for bladder distension. And that's going to be important. The urinary retention does occur because it's caused by the increased bladder tone. And so that's what causes the retention. Cough suppression, again, need to cough sometime during the day. So you want to make sure that they are increasing their fluids, assess lung sounds. They're going to cough. You do need them to cough. So sometimes, especially if they're getting rid of an infection, coughing is being able to produce or release some of that mucus that is causing their infection. So you don't want to suppress it completely. Sedation, again, if they are feeling too sedated, you want to be able to teach them not to drive or use any motorized or machinery until they know how it's going to affect them. And you want to avoid any activities that require any type of alertness as well. And this will also be able to, must be included in their education. Biliary colic, especially with morphine, is very common. Morphine can cause gallbladder attacks, so you want to see if you could stay away specifically from morphine and give meperidine instead. if they have some type of history of gallbladder disease or gallbladder issues. Nausea and vomiting, very common adverse effect with the opioid agonists, and you want to be able to have antiemetics available for them and to be able to administer for them. And then histamine release, especially with morphine, is going to cause vasodilation, orthostatic hypotension, and flushing. With your opioids, the abuse potential increases with long-term use or high dosages when we're providing for them. So withdrawals can actually occur as quickly as 2 weeks, especially if the patient is naive to any opioid use in the past. So if they've never had opioids in the past, they're going to be much more prone to going through withdrawal if you stop giving them the medication. An allergy, the thing with the allergy is you want to make sure that it's not a histamine reaction. Natural opioids like morphine cause the most histamine release. Synthetics like meperidine cause a low histamine release. So before you say that the patient is allergic to the medication, you might want to try changing the opioid agonist from morphine to meperidine, which will then see if the effects are less, which means that they're not actually allergic to the medication, but they're just suffering from an adverse effect of the medication, of one medication or the other. Again, withdrawal symptoms in longer acting opioids usually do not appear for 24 hours after discontinuing the opioid, and they may be milder. So you will get a milder withdrawal from the long-acting opioids than from the shorter-acting opioids. Shorter-acting usually will appear within 6 to 12 hours after discontinuing the medication. And then the recommendation is 2 weeks of gradual discontinuation of the medication. So tapering off of these meds is what's recommended in order to prevent the harshness of the withdrawal symptoms. Morphine metabolites can accumulate if the renal impairments, if they have a history of renal impairments, because it is excreted via the kidneys. So that is one thing you need to also take into effect and into consideration when giving the morphine to your patients that have some type of renal impairment. Okay, so as we continue now, we're going to talk a little further about the opioid agonist and opioid overdose triad. It refers to the symptoms that you will see when you have a patient that has taken an overdose of the opioids, and it's coma, from the severe sedation, respiratory depression, and pinpoint pupils. As nurses, we need to monitor their vital signs, place them on a vent, or the physician will place them on a vent, administer Narcan, then naloxone, which is the opioid antagonist, which will help to reverse the effects of the opioid. So the opioid overdose triad is something that as nurses you get used to seeing, especially those who work in the ER or in ICUs. They see the patients coming in with an overdose, and these are the symptoms that are very common that they see. Contraindications for opioid agonist use. Again, with morphine, patients that have had biliary tract surgery or premature infants because of the respiratory distress that it causes. Meperidine, patients that have renal failure, the accumulation of the metabolites can cause neurotoxicity and seizures. And because the opioid and agonists are excreted by the kidneys, patients with renal failure are at higher risk of showing neurotoxicity. So these are contraindicated for these patients. Caution that you want to take with certain clients. Respiratory issues, so patients with asthma and emphysema, you need to give opioids with caution. Patients with head trauma, due to the risk of respiratory depression. Patients in labor, so when we give opioids for pain for women in labor, it can decrease the uterine contraction, so it will make the contractions less intense, which in turn will then make the labor progress slower and take longer. And if the baby is delivered soon after the opioid is given, it does cause respiratory distress in the newborn. So there is a cutoff window. Usually we don't like to give them opioid for pain if we know they might deliver within the next 2 hours, because the baby will come out with respiratory distress and we might end up having to give the baby Narcan. Pregnancy in general, due to the risk of physical dependence in the fetus, the opioids do cross the placenta. So if mom is taking the opioid, so is baby, which will then cause the baby to get physically dependent on the opioids. And then once the placenta is delivered or once the cord is cut, then the baby goes through withdrawal. And then these babies end up in the NICU with neonatal abstinence syndrome. Extremely obese patients, meds again are metabolized slower. With extremely obese patients, they have a risk for prolonged adverse effects because the metabolism is slower, so it's longer in their system. Inflammatory bowel disease, risk of the megacolon or paralytic ileus is, so patients with bowel disease are more at risk of getting these. And then the hepatic or renal disease, because of the urinary retention, is an adverse effect. These patients usually, we want to give it with caution. So all of these are, they're not completely contraindicated, but they do have a caution label on them. So when we do give these opioid agonists to these patients, we need to do it with caution. All right, so still talking about opioid agonists, we're going to discuss their interactions. CNS depressant medications, so barbiturates, benzodiazepines, alcohol, will have an interaction with these meds. They will have an additive CNS depression effect. So you want to advise the client to avoid taking these meds while they're on opioids. Anticholinergic agents and tricyclic antidepressants also have an interactions. These meds, examples of these meds would be like atropine or scopolamine, will cause them to have constipation, urinary tension. So again, have an additive anticholinergic effect with the tricyclic antidepressants. So you have to give these with education and with caution. MAOIs with the meperidine will cause hyperpyrexic coma. Symptoms of the hyperpyrexic coma: excitation, seizures, respiratory depression. MAOIs are your monoamine oxidase inhibitors. So this is something that you don't you want to look into or prevent from giving them together. Antihypertensive meds. Again, these might have an additive hypotensive effect with the opioid agonist. Amphetamines, clonidine, and dextromethorphan. These also will have an increased risk of opioid-induced analgesia. So you'll have that increased sedation effect with these meds. Nursing considerations to remember with the opioid agonist. You want to be able to withhold the medication if any of the vital signs are abnormal. If your patient condition is declining, you want to be able to monitor them for any adverse effects and assess their pain regularly, assess their baseline and continuously monitor their blood pressures, vital signs, especially their urine output. Again, the parameter is if the respiratory rate is less than 12 breaths per minute, you want to notify the physician and stop giving the medication. You want to be able to monitor for urinary retention. Important to know when you're administering these opioid agonists, especially if you're giving them IV. You want to give them slowly IV. It's within a 4 to 5 minute push. You want to be able to have naloxone nearby and resuscitation equipment nearby as well. Monitor the site, especially if you're giving very strong or potent opioid agonists. You want like fentanyl or hydromorphone. These will cause immediate release, immediate reaction, and so you want to be able to have resuscitative equipment available if it's necessary. Clients with physical dependency to some type of other opioid, you don't want to discontinue abruptly, so you want to be able to taper off the opioid that you're giving them over a 3 to 5 day period. And again, if you're giving these meds through a PCA, you want to monitor closely your pump settings. You want to make sure that your pump is administering the right dosages of your medication. Okay, so continuing on with the opioid agonists, again, with patient teaching, you want to make sure, again, PCA, educate the client on how to use the PCA. So you want them to know that to make sure they're giving themselves the pain medication before the pain gets severe, before activity that could increase pain. So you want to give them education on how to use the PCA properly, which will make it much more effective for the patient. First administration of fentanyl patch may take several hours in order to be able to reach their therapeutic effect. Administering fentanyl patches, again, the area should remain clean and dry, should be non-hairy area. You want to rotate the sites. You want to use a new patch every 3 days, which will help with compliance as well. The advantages of using the patch is that it does avoid the first pass. This will in turn increase compliance because you're not getting a lot of those symptoms or the side effects. You want to be able to take medication with food, especially if the patient's already complaining of GI upset. And again, remember to take the medication before it reaches pain max, or that the pain is reaching a severe level. It will take longer to work and make their pain better if they're letting the pain get to above a 5 each time they take it. Evaluating effectiveness of these opioid agonists, again, basically, very obviously, you want to know that the relief of pain. So knowing that the patient is feeling better or having relief from their pain is basically knowing that the medication is being effective. If they're taking it for cough suppression, if their cough is being suppressed for most of the day, or most of the time that they are taking the medication, it is proving that it is effective. And same thing with resolution of diarrhea. So if the diarrhea has stopped, then we know that the medication is working, because it also is given for your GI motility. It decreases the GI motility. So those are all important factors to be able to use to see how effective your medication is being. Okay, so now we're going to discuss agonist, antagonist opioids. These are going to include your meds like butophenol, pupifine, your buprenorphine, and your benzocaine. These are all agonist, antagonist opioids. So the mechanism of action for these, for this class of opioids, is going to include mu antagonist. So the mu antagonist, of course, will then prevent the mu response, and kappa agonist will produce the kappa response. So that's why they're agonist antagonist opioids. Exception to this would be the buprenorphine, which is an mu agonist, and a kappa antagonist, which is it's still an agonist antagonist, but it reverses the normal flow of receptors. Most of your agonist antagonist opioids will have antagonist mu and agonist kappa. Benefits of this class, again, you have less potential for abuse, so only a little euphoria feeling, so it creates less of a potential for abuse. You have less risk of respiratory depression, and you have less analgesic effect. Adverse effects that you will see with this class, when given in high doses, it can create anxiety, restlessness, and mental confusion. You will have abstinence syndrome, which is physical cramping, hypertension, vomiting, fever, anxiety. These are the physical symptoms, and it can happen when a patient is physically dependent on the opioid agonist. They need to stop taking the opioid agonist in order for this to stop. Other adverse effects: sedation and respiratory depression. Again, monitor the respiratory rate. Have naloxone available, resuscitation equipment at the bedside as well. Other adverse effects: dizziness, which is especially patients need to be cautious when driving or standing up, and headaches. So you need to monitor for these headaches or for level of consciousness. So continuing with the agonist, antagonist opioids, uses for this class is going to be due to their less sedative quality. So they produce less sedation, less respiratory depression. So this class will be used as relief for moderate to severe pain. We use it to treat opioid dependence. Especially we use buprenorphine, and that is used to help treat the opioid dependence. Because remember, as in the previous slide, your buprenorphine is opposite the normal agonist and antagonist role, where they will have an agonist to the kappa and an antagonist to the mu, rather than the other way around, which is what the usually is. Adjunct to anesthesia. So we might use these as an adjunct to anesthesia during surgery, and then in labor, for our patients that are pregnant in labor. We would use these agonist, antagonist medications. In labor, we've really kind of lost or discontinued a lot of our use of opioids during labor, because of how it's so difficult to control, and it's very not really long acting enough for patients in labor, so we would have to give them frequent doses. And then also the frequent doses, since it does cross the placenta, it's very difficult to predict when she will deliver. And you had a lot of babies that needed to be given Narcan because of the respiratory depression that it causes in the infant. So we've kind of steered away from its use as a labor pain medication, but it is still used in some places. Caution in clients with history of an MI, renal and kidney disease, respiratory depression, patients with head injuries, or patients that have already some type of physical dependency on opioids. So remember when we discussed that to give it caution with clients, it means that this is not an absolute contraindication, but it is a condition of concern, and we just need to monitor more closely these patients that we know as that have conditions that we need to be precautious or be cautious with. So continuing with the agonist, antagonist, their interactions, again, CNS depressants and alcohol will have an additive effect. Opioid agonist, so can antagonize and reduce the analgesic effect of the opioid, because you're giving an agonist antagonist, and then now you're giving it along with another opioid agonist, and it basically cancels out the opioid, and then the patient doesn't get any analgesic effect at all. Nursing considerations that we need to consider, again, know your baseline. vitals, and then monitor your vital signs closely, looking again for the magic number, respirations less than 12. You want to hold it. Have naloxone and resuscitation equipment at the bedside always nearby so that you are ready if the patient does show signs of overdose. And assess the patient for opioid dependence, especially if they were patients that never had had an opioid in the past. They're going to be more prone to having stronger effect from it, and those that have had it in the past, when you're giving an agonist, antagonist, whatever they're physically dependent on, it can have the antagonist effect on that opioid. So prior to administration, it can trigger a withdrawal symptom in the patient. And so, and this is known with, like, let's say if a patient was taking a opioid agonist like methadone, and we gave her an opioid agonist antagonist like Stadol, which is I believe it's your butophonol, and they cancel each other out. So the patient ends up going through withdrawal symptoms from the methadone. So it can have a interaction and then cancel itself out. Patient teaching, again, do not increase the dosage without consulting their physician. Use caution when getting out of bed or standing, especially driving, until they know the effects of how it's going to affect them. And again, evaluation of effectiveness. So if they have relief for pain, we know that it's working. Okay, so finally we're going to discuss your opioid antagonist. And these are going to include meds like naloxone, naltrexone, your methyl naltrexone, and your alvimipane. The mechanism of action for these opioid antagonists, again, they're going to compete for the opioid receptors. You're going to use these opioid antagonists in treatment of opioid or alcohol abuse. Your naltrexone is what's used for alcohol abuse. It's going to prevent the euphoria. You want to reverse respiratory depression like the naloxone does, especially the respiratory depression if they've taken too much of the opioid and they're taking an overdose, or for our infants and fetuses that are born and they were born too soon after mom received a narcotic. And then you also give them for reversal of your opioid-induced constipation. So your methyl naltrexone and your alvimipane is what's used for that as well. Adverse effects. Just as an aside, under uses, we also want to note that there are only 3 states that actually require a prescription for naloxone. These 3 states are Hawaii, Nebraska, and Wyoming. So naloxone now is non-prescriptive. It's available in 2 4 milligram 1-dose sprays, or 4 2 milligram 1-dose sprays. You deliver 1 spray The copay is basically $10 or less. So you can buy these through the pharmacy without a prescription. And so lots of times, lots of clinics and places where they have lots of people that may come in having taken too many opioids will then allow them to be able to give, and it teaches them how to give the naloxone. So that's something to remember, and to, as an aside, it's also important to know that it may require multiple doses due to the 60 to 90 minute half-life. And the nasal spray was approved by the FDA in 2015. It developed for community use only. So Narcan website, that's on the Narcan website, which you can go and see, www.narcan.com. And its approval fast-tracked, basically, especially lately, due to the opioid crisis that we are in. Adverse effects that these opioid antagonists do have: tachycardia, tachypnea, and abstinence syndrome. So your tachycardia, again, you want to monitor your vital signs, your heart rhythm. It's going to have, patients will have a risk for ventricular tachycardia. Tachypnea, again, monitor your respiratory rate. Have resuscitation equipment nearby during the administration. And then abstinence syndrome. So it can occur if the patient is physically dependent on the opioid agonist. So it's going to completely block them off. So if they have an opioid in their system and you give them this opioid antagonist, it will stop. It will break that connection that it has with the receptor, and it'll stop the opioid from working. And then the patient's going to completely not have the opioid anymore and go in complete withdrawal. And then patients will go through withdrawal symptoms. Contraindications for this class: opioid antagonists, again, naloxone and naltrexone. Clients who have an opioid dependency, you don't want to cut off their opioid that quickly or not abruptly. It will cause them to go into withdrawals, and they'll have that withdrawal syndrome. So you want to be able to taper it off. It's going to be much healthier for the patient. With naltrexone, patients with acute hepatic disease or hepatic failure, you don't want to give the opioid antagonist medications, and patients who are lactating also, because it will travel through the breast milk, and it is metabolized by the liver, so the patient will metabolize it and then pass it through the breast milk as well. Nursing considerations that you do want to consider with naloxone: you do not give it PO. It has a very rapid first pass, which in activation, which if given PO, so if you give it PO, it will inactivate the medication because of the first pass phenomena. And then you have, so you want to give the naloxone sub-Q, IM, or IV, or nasal. You want to titrate the dose to achieve reversal of the respiratory depression without full reversal of the analgesic. And sometimes that might be hard to do depending on the situation that you're in and depending on the client's depending on the client's symptoms of withdrawal and so, or of the opioid reaction. So you want to be able to make sure that they are you titrate those dosages. Observe for withdrawal symptoms or abrupt onset of pain. Do not rapidly infuse, can cause hypertension, tachycardia, or nausea and vomiting. You always want to monitor the respiratory rate for 2 hours after using the naloxone. You want to assess for recurrence of respiratory depression or need to repeat the dosage. Remember, because of their 60 to 90 minute half-life, opioids may outlast the naloxone, so you may have to give other doses or another dose. Alvimopane, the nursing consideration for this one, again, you want to only administer for 7 days, so you don't want to give it for longer than 7 days. It does have an increased risk for NMI if we give it for prolonged periods of time. So that basically concludes our opioid section. We're going to start with our non-opioid analgesics, and that we'll start with acetaminophen. Everyone knows acetaminophen as Tylenol. The mechanism of action is that it slows production of the prostaglandins in the central nervous system. We use acetaminophen for analgesic effect. It inhibits the prostaglandin synthesis, and that's how it helps to take away pain. And we also use it for antipyretic properties. It does act on the hypothalamus to lower the body temperature. Adverse effects that we see with acetaminophen are usually rare. They only really occur with excessively high doses. One of them would be the acute toxicity. So you'll see nausea, vomiting, diarrhea, sweating, abdominal pain. This can lead to, it can progress to liver failure. It can lead to liver necrosis, cause coma or death. With acute toxicity, because remember I said that these usually occur only with excessively high doses. Death may occur from ingestion of more than 15 grams of acetaminophen. Acetylcysteine antidote. Acetylcysteine is the antidote for acetaminophen, and if we find ourselves in an acute toxicity situation, it will protect the liver. Most effective when given within at least 10 hours. It prevents the acetaminophen metabolites from forming, which are hepatotoxic. The medication does smell like rotten eggs, and it can be given nasal gastric, oral gastric, or IV. Acetaminophen should be used with caution in patients who consume 3 or more alcoholic beverages a day, and patients who are on warfarin. It will interfere with the metabolism of warfarin, so patients might have an increased risk of bleeding, because the acetaminophen is affecting the metabolism of the warfarin. Interactions that you might have with acetaminophen. Again, warfarin is going to be your main one, so you want to monitor your PT, your INR levels. You might need to adjust the warfarin dose if they're going to be on a continuous acetaminophen regimen. Also, interactions we might see will be with alcohol. So you want to educate your clients to avoid the use of alcohol, so that you don't have these interactions. Causing nursing considerations that you want to take into effect is, again, monitor the total acetaminophen intake. Remember that dosages above 15 grams can be fatal for patients. So we need to monitor the amount of how much they're taking. And remember that when we discussed our opioid agonist, combining your oxycodone with your acetaminophen in a medication such as Percocet is very common medication given for pain, and this has at least 325 milligrams of acetaminophen. So if you've got a patient who's taking Percocet for 2 tablets every 4 to 6 hours, they can easily reach a high dose of acetaminophen intake. So you want to be very cautious with how much they're taking on a daily basis. Patient teaching, again, take as prescribed. You don't want to exceed a 4 gram per day limit. So patients who are undernourished will have a decreased limit of 3 grams per day because they weigh a lot less, and so they might get to their peak of when they should stop taking the acetaminophen, much lower dose. So 3 gram limit per day for them. You want to realize that 3 alcoholic drinks or more. So if patients that are taking 3 or more alcoholic drinks a week, also should be limited to the 2 gram per day limit. Tylenol now limits to 3,000 milligrams per day for the most part. So even though it used to be a 4 gram limit per day, in practice we are seeing now that most hospital pharmacies are reducing that limit to 3 grams per day. But for the most part, in most places, it's still 4. So we're going to keep that number as part of what you need to know for your testing purposes. More for patient teaching, you want to make sure that you are letting them know to read the ingredients, especially on their over-the-counter medications that they're taking. Acetaminophen is often found in a lot of combo meds. You want to take only one product that contains acetaminophen at one time. Evaluating effectiveness, of course, the most obvious is that the pain is relieved or the fever is reduced, and that's going to be how you would evaluate how effective using the acetaminophen is. All right, so now another non-opioid analgesic that we're going to discuss is NSAIDs. And your NSAIDs, again, stand for your non-steroidal anti-inflammatory drug. Meds that are going to fall under these non-opioid analgesics are going to be your aspirin, ibuprofen, naproxen, and your COX-2 inhibitors. Their mechanism of action is going to be that they do suppress pain that is related to inflammation. This class adverse effects are going to be GI upset or bleeding. Aspirin is going to have a specific adverse effect, and it's going to be Reye's syndrome. And Reye's syndrome causes swelling in the liver and in the brain. Most often affects children and teens recovering from any type of viral illness. Especially most often it's the flu or the chickenpox. So one of the nursing considerations that are going to be important to focus on is the age of the client. You do not want to give it to teens or children because of the, especially aspirin, because of the risk of Reye's syndrome. You want to assess your kidney and liver function labs, because that's also going to be something that can be affected by the NSAIDs. You want to gather information related to any type of GI disorders. The NSAIDs may have GI upset, may cause GI upset, so you want to see if they do have any type of GI disorders that may be exacerbated by the use of NSAIDs. And again, you want to assess the patients for any bleeding or ulcers that they might have prior to taking the NSAID. Okay, so another non-opioid analgesic is tramadol, hydrochloride, or Ultram. And Ultram creates a weak bond to the mu opioid receptors. It will inhibit the reuptake of norepi and serotonin. It is used for treatment of moderate to severe pain. It also can be, absorption is usually unaffected by the use of food, so it doesn't necessarily help to or diminish the absorption if you take it with food or not. It can elevate renal excretion. Adverse effects that you will see are going to be similar to those of opioids, so such as drowsiness, dizziness, headache, nausea, constipation, respiratory distress, and seizures, especially those of greater risk. Those taking drugs with decrease for seizures, it's going to decrease the seizure threshold. So meds such as SSRIs, MAOIs, or neuroleptic medications. Other adverse effects, it can increase the risk of developing serotonin syndrome if it's taken with SSRIs. So that's also important to know. Your contraindications, again, any allergies to opioids because of the risk of or potential to cross reactivity. Not recommended for use in patients that are 75 years or older, just because of the declining renal function that the older population have, because it is eliminated via the kidneys. So a patient's kidneys should be functioning properly in order to be given this medication. Nursing considerations, fall risk and injury prevention, again, because of the dizziness and drowsiness. Avoid taking tasks that need mental clarity. So you want to make sure you're educating your patients regarding injury prevention. You want to also observe the patient needs to remember that they need to be taught to avoid the tasks that do require any mental clarity and alertness, and you need to observe for headaches or nausea, constipation, and respiratory depression as well. All right, so another non-opioid analgesic is the transdermal lidocaine, which is a topical anesthetic patch. It's placed onto the painful area of the skin. It provides local pain relief. The patch can use up to 3 patches. Can be placed on a large area, so you can, if you have, let's say, all of your back that hurts and you only have small amounts, a smaller size patch, you can use up to 3 patches at the same time in a large space. Not to be worn for longer than 12 hours per day. This will help to avoid your systemic drug toxicity, which will cause dysrhythmias. You want to minimize the systemic adverse effects of the patch. Minimal systemic adverse effects, because it is a patch and it's going through the skin. You have very little systemic effects of the lidocaine. If you apply it, you must apply it only to intact skin. You don't want the skin to have any blisters underneath the patches. The pain relief usually lasts 4 to 12 hours. The results will probably vary depending on the habitus of the patient and how quickly the medication is metabolized in that patient's system. Lidocaine transdermal, you want to make sure that you are assessing hepatic lesions or surrounding skin around the patches. You want to keep the patches away from children. And you want to monitor your liver function testing, because it's it is metabolized by the liver. Again, patient teaching, the main thing is going to be to keep away from children. They might think it's a sticker or a Band-Aid, and kids have much thinner skin. And they can get toxic much quicker. Okay, so general nursing considerations for all of these analgesics, both your opioid and your non-opioid, is that first you want to always start with the lowest dose and then titrate upward. Rectal dosage is not appropriate for patients with diarrhea or stomatitis, which is a mucosal inflammation around the stoma, or patients with low white blood cell count because of the potential that it can introduce infection. You want to always develop some type of goal for pain management with the patient. So what is tolerable for the patient is what you want to be able to gain knowledge of, and then make a plan to be able to reach either below what they're able to tolerate or at that point. Collaborate with other members of the healthcare team in order to select regimen that is going to be easy for the patient to follow. You want to be familiar with equal analgesic doses of opioids. So you want to be able to make sure that you're reaching out and giving them the appropriate dose for their pain interaction or for their pain assessment. Use preventative measures in order to manage the adverse effects. So make sure that you're educating them about their adverse effects, and use measures that are going to help to prevent these adverse effects rather than having to treat them. You want to identify community resources that can assist the patients with pain management. You want to make sure the patient is on fall precaution because of the sedative effects and dizziness, and will cause them to fall or can cause them to fall. And then you always want to monitor their vital signs, level of consciousness, and make sure that their labs remain normal. Patient-centered teaching. So, patient-centered teaching that goes along with these types of your analgesics, both your opioid and your non-opioid, again, is that opioids should not be mixed with any alcohol or other CNS suppressants. You want to look at the ingredients of over-the-counter medication. Acetaminophen is used in a lot of different meds, and you want to know what meds you're using. So you want to be able to maintain yourself at the below the daily limit of acetaminophen use. Complementary modalities for pain. So you always want to try your non-pharmacologic methods first. You want to be able to report to your PCP any dizziness or low blood pressure, excessive sleepiness, confusion, or memory loss. These are going to be important to be able to report to your PCP. Opioids may cause constipation, so you want to make sure that the patient is encouraged to drink lots of fluid and increase their fiber intake. You want to report any nausea and vomiting. Activities requiring mental clarity or alertness need to be avoided, especially if the patient is feeling dizzy or drowsy during the time that they want to drive or walk or do anything that needs that mental clarity. You want to have the patient share any past medical history of addiction, which will then help to be able to know which opioids, we can give them. Use of long-acting opioids, especially if there's a history of that substance abuse, we might want to change or give them smaller doses. So we need to know that. You want to know what their tolerance, that tolerance can occur with opioid use. So you want to make sure that patients know if morphine or morphine-like drugs are used, that there is a potential for addiction. You want to constantly keep the patient informed of all the treatment options that they have. And tolerance does occur with opioid use, and so it does require greater dose for the same effect. So not the same thing as dependence. Only function normally with drugs. So basically, you want to make sure that your patient knows that tolerance can occur and that it's not the same as dependency. And again, you want to make sure you're instructing your patients to take the pain medication before the pain gets so out of control that it's very difficult for them to get any pain relief. Okay, so I hope that this was clear. Don't forget that you can reach us in my office or after class if you need any type of explanation. These here is your references, and it does just have some important notes that I wanted you guys to know, like analgesia is providing equivalent pain relief of different drugs. So making sure we're giving the patients different drugs will cause the different types of pain relief. So we want to give them, providing them equivalent pain relief by giving them similar drug and similar drug classes. So for example, hydromorphone dilaudid is 7 times more potent than morphine. Ability to provide equivalent pain relief by calculating the dosages of different drugs and routes of administration that provides comparable analgesia. Again, example, 1 milligram of hydromorphone is like giving that patient 7 milligrams of morphine. And this is basically what we do. We try to make sure we're titrating the medication. So if we don't have to give them the most potent at the high maximus dose, you want to always start low and then titrate upward if you need to continue giving them this opioid for pain relief. And again, like I said, you can reach us in our office and or call us if you guys have any questions. Thank you.